Hello, my name is Jasna Schwind. I'm an associate professor at the Daphne Cockrell School of Nursing at the Toronto Metropolitan University in Ontario, Canada. This presentation on the nature and development of knowledge in nursing was prepared for a conference hosted by the Federal University of Santa Maria in southern Brazil, which was held on June 10th, 2022. The conference audience consisted of professors and graduate students, including nurses, nutritionists, and physiotherapists. I live and work in Toronto, Canada, in the shared territory of the Anishinaabe, Mississaugas, and Haudenosaunee. As a settler, I am grateful for the privilege to live on this land with all living beings in the spirit of harmony, peace, friendship, and respect. While my work and consequently this presentation reflect my North American perspectives, I recognize that colleagues from around the world may have different experiences and perspectives on what knowledge is and how it is constructed in nursing. I trust that this presentation will offer another point of view for your consideration. Reed and Shearer, nursing researchers, wrote, "Science, philosophy, theory, and practice exist in a complex relationship that generates knowledge for nursing. However, what goes unrecognized in healthcare and unclaimed by nurses is their capacity for theoretical thinking and development of theory for practice in practice. We are moving away from focus and application of knowledge in practice, which was historically developed out of context. We are now exploring the how, or the origination of knowledge development for practice in practice, which is contextual, person-centered nursing practice. Thus, contextualized knowledge development for practice promotes a direct link between theory and practice, and so evolving nurses' identity from simple knowledge users to knowledge producers. So these are the following are the questions to ponder as we consider knowledge development in nursing. What is knowledge? How do we construct or create or generate knowledge? Where does knowledge come from? What do we do with knowledge? How does knowledge inform our profession? According to nursing researchers, Chin and Kramer, knowing is a way of perceiving and understanding the self and the world. It is fluid and internal to the knower. And we know more than we can say. Also, there is a sense of gestalt in that the whole of knowing exists in the present moment. In other words, knowing is a unique and particular awareness that expresses the being and doing of a person. Now, knowledge is knowing that is expressed in a form that can be shared or communicated with others. From the philosophical perspective, paradigms, assumptions, theories, principles, and concepts provide structure for knowledge development and guide research, practice, and education of that discipline or profession. In order to be labeled as a discipline or a profession, there must be a unique body of knowledge that guides the practice, research, and education of its members. Therefore, knowledge grounded in research is essential for reasoning and decision-making, both of which are central to professional practice. There are two general types of knowledge, one being propositional knowledge. We understand that to be empirical, theoretical knowledge, or research knowledge, which we recognize and understand as being acontextual. So it is abstract, and it shows us logical and formal relationships between concepts. And then we have the non-propositional knowledge, which is really professional craft knowledge or tacit knowledge of the profession. It is also recognized as personal knowledge, which is tied to the individual's reality or experience, falls under this umbrella of non-propositional knowledge or contextual knowledge. Now, philosophical perspectives are a set of assumptions about reality that underlines the questions we ask and the kinds of answers we arrive at as a result. Paradigms provide frameworks for generating knowledge and dictate what sorts of knowledge claims are considered acceptable. Theoretical lens provides a framework for interpreting what we observe. So type of knowledge desired will determine the research question asked, which in turn will determine which paradigm is adopted for conducting the inquiry. This is also true in reverse. The worldview of the researcher will determine the type of question asked based on the knowledge desired, and thus the two are mutually informing. Although there are different paradigms for our purposes today, we'll note the participatory paradigm. Participatory perspective is linked to feminist, holistic, emancipatory, and postmodern perspectives. Participatory worldview recognizes our cosmos is the person-environment field, which means that our knowledge arises from practical activities and involves multiple ways of knowing. In other words, it values temporality beyond causality and relational ethics, and is connected epistemology to ontology, so that it is more holistic, and it is including the person, the knower, and the known. It is once again contextual because it includes the I, the subject. Now, a scientist's ability to theorize reflects a person's ability to continue to learn, to be open to new thinking, and to define the world in new ways. All thinking is impregnated with theory, especially our scientific conceptualizations. Theoretical thinking in nursing, and particularly nursing practice, may be described largely by the process of abduction. Abductive reasoning is more than the mere combination of inductive and deductive logic. It is a dominant pattern of practitioners. Scientific findings are constructed more than discovered, but they are neither arbitrary nor are they constructed out of nothing. So Reid notes that abductive reasoning is the process of formulating plausible explanations from empirical observations and other knowledge sources. It expands beyond the information at hand. It is useful in situations where knowledge and protocol are lacking and where solutions are neither clear-cut nor easily solved. The experience or observation occurs first, followed by generation of hypotheses or potential explanations. So, knowledge, nurses and knowledge. The art of knowing demands skill in selecting appropriate sense data on one side and connecting principles or conceptual theories on the other. Experience is uncontrolled, uncertain, and problematic. An interaction of a person and a social situation is neither sensible nor conceptual. Sense data and interpretive ideas are brought together. Conclusions are contingent, tentative, partial, subjective to revision and further evidence. So knowledge results from data and principles brought together. Once again, we have all aspects of knowledge and ways of knowing being brought together. According to Dewey, all reflective thinking is a process of deducting relations. So good thinking is not contented with finding any old kind of relation, but searches until a relation is found that is as accurately defined as conditions permit. So to grasp the meaning of a thing, an event, or a situation is to see it in its relations to other things. What consequences follow from it? Good thinking is looking for relations and looking for connections, making visible our own assumptions. So thus far, we're looking at holistic ways of thinking, being, and doing, recognizing and appreciating that all types of knowing and knowledges informs who we are as nurses, as practitioners, and that these inform how we create knowledge in practice. And to do that, we need to speak our knowledge. The nature of nursing requires that nurses think theoretically and speak of their knowledge. That is very, very important because historically, nurses were perceived and basically, I'll say pigeonholed as being knowledge users and not having a voice. But as we see through this presentation, how through history we have evolved to find our voice, to speak our knowledge in order to create a richer experience for our patients, for ourselves, for humanity. In order to do that, which is to speak our knowledge, we need to engage in reflective practice. However, if nurses as practitioners and educators do not have the capability to articulate the nature of nursing knowledge in relation to health that signifies the process of practice as part of whole provision of healthcare, then reflection and practice remains an ad hoc academic procedure. So again, very important, if we value knowledge development and speaking our knowledge, then we do this through individual and collective reflective practice, because there is no, according to John Dewey, there is no evolution, intellectual evolution, without some kind of reflection to make sense of our actions. So if we do not do that, we again do not have the opportunity to evolve as active practitioners who are knowledge producers beyond simply using the knowledge that we are given. And sometimes, from my experience, we speak well about the need for reflective practice, for engaging in reflective practice, but it remains at lip service. It's only words, because in reality, there is no time provided for reflective practice. In clinical practice, for example, in patient care, nurses are so stretched, so busy, such high demands on them that there's no time to sit down and reflect on their work, on what they just did, or how they would like to do something differently in the future. So we need to really put into practice what we believe and what we value. And if that is reflective practice, which I recommend that we do indeed, then we need to create time, provide time and space. So what is it like not to know, to be uncertain, to feel unsure? Just think about, what do you do when you feel that way? Consider that for yourself. We'll start there. So let's start with unknowing. Knowing may lead to closure based on confidence in one's own interpretation. Unknowing being related to all patterns of knowing connects at that very root level where unknowing allows us the potential to learn. And Munhall in the 1990s described unknowing as an art, which is closely related to personal knowing, being open to possibilities, to discovery, to engagement. And so the need for the nurse to approach each new encounter with an openness and readiness for all possible types and sources of knowledge is imperative, so that we don't close off too early the opportunity to know. So unknowing places nurse within their own social context and acknowledges an ignorance and opens the nurse to patient's subjective world. For those of us who worked in clinical practice, there are times when we, all of us, especially when we were younger perhaps and didn't know, that we needed to remain open to the patient's subjective world, their experience of their illness, for example. And as a nurse, as nurses, we may say, oh, of course, I know those signs and symptoms. I know that's what it is, but maybe it's not. So there is also, with unknowing, there's a sense of humility, being open to be in that vulnerable place of receiving the information in a respectful, humble way, allowing the patient's lived experience to emerge and for us to receive it gracefully, with respect, and then to add our own experiences as professionals, and including, of course, the empirical knowing, our scientific knowledge. So all of these come in together to create the best possible outcome for the person in our care, which in this case would be our patient. Christopher Johns, again in the 1990s, he's now retired, but was a scholar and who worked very much with reflective practice in clinical practice in hospitals with nurses. And he noted the need to reflect on the mundane as well as critical incidents. And I know that oftentimes we work on focusing on critical incident debriefing, but also there's a great value on the everydayness of what it is that we do as nurses. So he says it's probably within the mundane that habitual, routinized practice is most likely to occur. And so when we do that, we take things for granted. Oh, it's always been done like that. It's always been done like that. But that prevents us from learning and evolving. So we need to then be aware that nurse does not and cannot know or understand the patient when they first meet, and so needs to remain, I believe, open to patients' perspectives. Very important. And in this way, unknowing provides a way to move knowledge development forward through deeply understanding meaning of experience. Again, from the patient's perspective, it is their experience that we are entering into. And so the assessment critical questions would be, what remains unknown? And how, when, and where theory and research may be used to produce desired outcome. So there are ways to increase knowing, and we can do that through dialogue and conversation with one another. We can do the dialogue can be also that reflective practice, which we can do on our own. And then we meet with peers to discuss our reflective thoughts and considerations and questions. And also, of course, dialectical question and answer, openness to meanings of each other, and questioning our interpretations. Because we, as individuals, of course, we come with our own life experiences, and thus we create our own perspectives. And through those perspectives, we create interpretations. But we need to question those. Not that they are necessarily wrong, but that's how we learn, and that's how we share our knowledge with each other, and we enlighten one another as individuals, as professionals, as a whole profession, as the healthcare providers. So it expands like dropping a pebble in the water, and the concentric circles expand. So therefore, through sharing perspectives, new understandings that were not imagined earlier are realized, and people change their minds, attitudes, and behaviors. Now, one taxonomy of knowledge development and enactment is Carper's Patterns of Knowing in Nursing. Carper, in the late 70s, identified 4 approaches she believed were needed to create knowledge in nursing: empirical, aesthetic, personal, and ethical. Chin and Kramer, researchers who were continued Carper's work in the early 2000s, added the emancipatory knowing. So for our purposes today, I will briefly touch on each of these patterns as we continue to talk about knowledge development in nursing. They need to be recognized as very significant contribution to our an evolving understanding of what knowledge is and how it is created and developed in the profession of nursing, and I argue in other healthcare professions. So colleagues who are listening to this, who are not specifically in nursing, may extrapolate the key points and principles shared here today to apply to their own profession. And if there are any differences, of course, ask yourself, what are the differences and why are they there? How are they different? Perhaps we can learn something from each other. Usually the answer is yes, we can. So empirical knowing is really systematically organized in general laws and theories for the purpose of describing, explaining, and predicting phenomena. And empirical knowing is expressed in practice through nurses' scientific competence. And the process of assessment is by replication. And I think all of us are very familiar with this particular pattern of knowing, very important, but this is not the only one. But the assessment critical questions that we would ask for the empirical pattern of knowing is, what does this represent, and how is this representative? So we have aesthetic knowing. Aesthetic knowing is really looking for meaning in a situation. In 2005, Daniel Pink noted that nursing art transforms experience from what is to what might be possible. So there is this consideration to go beyond just the observation. The ability to participate in experience in such a way as to inspire new possibilities and to facilitate a healing path. He further writes that empathy and intuitive knowing are important components of perceiving and envisioning. So you can see the envisioning has that note of imagination of the possibilities. And the growing recognition of empathy's role in healing is one reason why nursing will be one of the key professions of the conceptual age workforce, which we have entered now in the 21st century, and more on that a bit later, which is the sort of emotionally intelligent care they provide is impossible to outsource or automate. So that our humanity is represented or expressed rather through this aesthetic knowing. And it finds expression in the art act of nursing. So the art and act of nursing are mutually informative and they work together to be whole. So the assessment critical questions for this pattern of knowing is, what does this mean? And what are the patterns of the whole? So again, we're looking more holistically at knowing and life. The pattern of knowing, personal knowing, is the most difficult to master and to teach. One does not know about the self, write Chin and Kramer. One simply strives to know self. So the inner experience of becoming a whole aware self is personal knowing, and it's expressed and communicated to others as authentic, genuine self. And reflection and interactions with others can lead to increased personal knowledge, which is socially situated. So by working together, first of all, individually, and then together, we are learning about who we are as persons and professionals, and how that informs how we engage with people in our care, with our colleagues, with our peers, and with ourselves. In my work, I use the metaphor of self as instrument of care. And so when I see myself as an instrument of care, how do I develop that instrument? How do I fine tune it so that I can most effectively engage with people in my care, that I can be of utmost service to those in my care and to those around me, to humanity? So the questions, assessment critical questions that we can ask is, do I know what I do? And do I do what I know? Is there a sense of congruence? Ethical knowing. Traditionally, nursing used by medical ethics for ethical knowing. It's still relevant, but it's insufficient. Ethics involves making moment-to-moment judgments about what ought to be done, what is right, and what is responsible. It guides and directs how nurses conduct their practice, what they select as important, what priorities demand advocacy. So the questions to ask, really, the assessment critical questions: is this right? And is this responsible? Emancipatory knowing. It is action and critical reflection and synchrony toward transforming the world. So this is the pattern that was added by Chin and Kramer in the early 2000s. Emphasis is on seeing what lies beneath the situation and uncover alternative possibilities for change. the capacity to critically examine social injustice, how that which is taken for granted as knowledge contributes to the social order. Emancipatory knowing acknowledges power dynamics that create knowledge, and it seeks emancipation from sociopolitical structures that are restrictive. And it is based on critical social theory. Now, praxis is the process of emancipatory knowing in action and reflection that are constantly interacting to shape and improve what and how nursing is done. So there is this notion of action. Whenever we think of emancipatory knowing pattern, we are doing something. It is active. So praxis requires more than personal reflection. It's not good enough just to think about it or to talk about it. What is important is that we do something about it. So it requires deliberately cultivating the ability to see what is unfair and unjust, envisioning how it could be different, uncovering alternate explanation and possibilities for change, and actually engaging in that change. So therefore, praxis requires both inward and outward reflection and action. And assessment critical questions that are, what are the barriers to freedom? What is hidden? What is invisible? Who is not heard? And who benefits? Very important questions for us to ask especially in our role as healthcare professionals, and specifically speaking to nursing. Sociopolitical knowing is not part of the patterns identified by Carper and then Chin and Kramer. This was a pattern identified by White and is akin to the emancipatory knowledge, and really speaks to the sociopolitical environment of persons and their interactions. So it's recognizing again the sociopolitical engagement, and invites really nurses to question taken for granted assumptions about practice, profession, and health policies. It recognizes cultural identity, where self is intrinsically located. And importantly, it enables all concerned to have a voice in care provision. And as we saw with emancipatory knowing, is again, who is not heard. We want to ensure that everyone has a voice. And when everyone has a voice, then we have a more equitable and fair and inclusive society, and all humanity benefits. So assessment critical questions include whose voice is heard and whose voice is silenced. So then nurses have a moral and professional obligation to advocate for social reform and can do so at many levels. They can ask such questions as what are the inequities in access to healthcare in my practice setting? What are the social determinants of health for my patients? Are there resource issues underlying non-compliance? Is lack of action on my part a form of discrimination? This is an excellent exercise for individuals, but can be done in the classroom with students. This can be done at the workplace setting as a professional development exercise. Because when we don't ask questions, we perpetuate the status quo. And status quo is not always the best way to evolve. What I want to say, and this is a North American saying, we don't want to throw the baby out with the bathwater. In other words, we want to keep what is important, what the learning, and discard that which no longer serves the greater good of the profession and of humanity. So very important to keep that in mind. Here's another activity that that may be done at a later time. And in what we call a think, pair, share approach is basically individually think and reflect. And I have the pointers revealed shortly, is that we think about it individually, then we discuss it in a pair with another person, a peer in the classroom perhaps, or a colleague, and then we share it then with a larger group. So things like, think of a recent nursing experience. What values, beliefs, and assumptions informed your thinking and influenced your actions? How did you think through what to do? What actions did you take? What were the consequences of those actions? What is the meaning of that specific experience? So what I would like you to consider is, how did knowledge contribute to this situation? What kind of knowledge came up? Which patterns are starting to show up? What paradigm are you situated in? So these are things to keep in mind as I, you, we evolve and we create and recognize that knowledge is continuously evolving. And what is the value of that knowledge? How does it inform who we are as persons and professionals? And so theory-based knowledge, we move now from the patterns, we identify those, and we move now to theory-based knowledge. We will not spend too much time in theory. It is simply an aspect of knowledge development. Historically, when we were I would say, stuck in the dominant paradigm of quantitative positivist paradigm, and where empirical knowledge was the only knowledge that was recognized as valid, then everything was done through that perspective, and theory was the only way to do it. But we recognize now that we need the positivist thinking, we need empirical knowledge, we need theory, we need all of that, but that's not all. We need to expand and recognize that knowledge and knowing is beyond observable facts. So historically, nurses in clinical practice have been seen as knowledge users, or as intuitive, naturally caring, mostly women, who do not need intellectual capacities to do their work. So you can see how nurses were seen simply as workers with no intelligence. Knowledge was traditionally produced by researchers and academics. Again, there's this differentiation of hierarchy. And there was much concern about the theory-practice gap. With this kind of traditional view, of course, the knowledge was created in an acontextual way. In other words, it was not situational. It was intended to be applicable to every situation. And we all know that we cannot possibly talk about every situation being identical. Not every gallbladder surgery is the same. Not every patient experiences their tonsillectomy in the same way. That is a fact of life. And I'm glad that as scholars and practitioners, we are finally coming to recognize this very important distinction. So now we look at nurses as knowledge makers. So Antrobus, again, another nursing researcher, built on Drucker's ideas about living in a knowledge society. She proposed that since knowledge constantly evolves, so must nursing knowledge. Yes, fully agree. We are already beyond using only medical and biomedical models as our only basis for practice. Nurses are no longer simply following orders in a cure-based disease model. So we now recognize in the 21st century that nurses are both knowledge makers and knowledge users. The process of inquiry into nursing praxis reveals construction of nursing knowledge in practice for practice. Again, very important. Now that a theory practice gap is small, in many places not even existent, because nurses are encouraged to adopt the role of clinical scholar in nursing praxis. Note the word nursing, praxis and clinical scholar. Those terms were not used a few years back, at least in North America. They are starting to emerge and be recognized. So we also, so basically, how do nurses theorize, we ask ourselves. Well, Lindsay and Smith observed that nurses as knowledge makers critically reflect on their praxis. Notice the word reflect again. They make connections, see patterns, and conceptualize their practice, which shows how one source of theory is our daily experience. Think of, again, Christopher John's observation that reflecting on the mundane informs how we are scholars, clinical scholars. So we also need to recognize that persons as autonomous beings have a moral right to participate in decisions that claim to generate knowledge about them. This, again, we are in clinical practice, and we are as nurses in relational practice with our patients or people in our care. So, as nurses, we need to recognize that people have the right to be part of generating knowledge that is going to be used by them. For example, nurses collect a great deal of information or knowledge on patients through assessment. So using Heron's idea, we would share with patients what we are doing with that knowledge. And we make connections, see patterns, note what is significant, decide what should be done. But the key thing is that the patients would be involved in decision-making about their own care. So that knowledge that we acquire by doing patient assessment about their illness or disease, we need to share that. Historically, I know when I was much younger, that patients were not told anything about their illnesses. And now, thankfully, that is the case. People are told about their illnesses. They're discussed. Patients are now considered as part of an interprofessional team. We have now, in North America speaking, but we have interprofessional care teams that include whatever professional is required for the person or for the patient in our care. So we may have physiotherapists, nurses, nutritionists, physicians, all in one team, sitting around the table together, and the patient may be there as well. My colleague, Katerina Matersky, has done a lot of work on patients' role as part of the interprofessional team. Patients are also creating and supporting this knowledge and developing different ways of knowing and helping us understand that knowledge is more expansive than we have given it credit. So questions to consider when we think about nursing as inquiry. How does each theory tell us how to be a nurse? That talks about our identity and ontology. What ideas matter in nursing? We're talking about epistemology. How do we know what we know? And what to do is actions with consequences, methodology, praxis. So this is, now we are looking at how research and knowledge development and practice are all mutually informing. It is not one or the other. It is not us versus them. It is all of us. And so we are starting to really recognize the humanity that we are all a part of. So inquiry-based praxis, what can nurses do? Well, nurses can ask about their practice. What kind of nurse do I want to be in this situation? What knowledge is evident through many ways of knowing? How might theory and evidence enlarge the possibilities for being with this particular patient in this specific situation? Again, note the contextual nature of this. This is another exercise for discussion in the classroom potentially, or even, like I say, in professional development in clinical practice. So according to Rounsley, being clinically expert is recognizing that paradoxical, creative thinking, tempered by tolerance for ambiguity, is essential in nursing science practice. And it distinguishes the clinical expert in nursing science from the rigid and rule-bound procedural technician in nursing. Very, very important note about evolution of nursing, of who we are as nurses and how we practice our art and science of nursing. So Reed and Lawrence further advise that practitioners as clinical scholars link empirical to the theoretical to explain events and help patients recognize patterns and meanings in what they are experiencing so they can participate more fully in their own health. So the clinical scholar regards knowledge as process, not product. And that process is inclusive of all aspects and everyone of a particular situation and a particular group of people, which in our case is nurses and as healthcare providers includes our patients. So nurses can also engage in dialogue, write Chin and Kramer. And I really like what they wrote here, and I will read it for you and to you. They write, they say, as you reflect on your experience, you see meanings that are different from the meanings of learning and existing learning theories. As you discuss your ideas with other nurses, you find that they have made similar observations. From this awareness, you can build a new conceptualization that, once named, can be incorporated into theory and used in practice. And this is where practitioner as scholar emerges and is empowered to generate knowledge. So nurses can also practice emancipatory knowing by critiquing the status quo from every point of view, including our own. Who benefits from the status quo? Think about that. We can imagine what equality looks like and how that world can be created. Does this mean we are all the same? How can we be more inclusive and respectful? How can we be more humble and open to learning? And we can also develop counter stories to the master narratives, the taken for granted stories. So create new stories of self-definition in the space between the master narrative, plot lines that limit people as moral agents, and what those people actually do and who they are. For me, this space is illuminated by thinking narratively and by exploring experience. My research background is as a narrative inquirer who uses creative self-expression, such as narrative reflective process, to augment knowing in education, practice, and research. So this is my perspective, but I know and recognize and respect that we each have our own perspectives. But when we talk about it, we can learn from each other. We can learn with each other. So now we move beyond the knowledge workers. And Daniel Pink proposed that we have moved from an 18th century agricultural age, farmers, to 19th century industrial age, factory workers, to 20th century information age, knowledge workers, to 21st century conceptual age, creators and empathizers, So this is the evolution of knowledge development that Pink identified for us. And he further identifies the 6 senses of conceptual age, to recognize that design matters as much as function, to craft a compelling narrative or story to make sense of experience, to move beyond specialization and focus to synthesis, seeing the big picture, the symphony. Add empathy to logic and understand and create relationships, key things. Add playfulness, such as humor and laughter, to life. Pursue meaning and spiritual significance. So this is all that we have talked about, how knowledge has evolved. And I'm sure that many colleagues around the world are doing this already. But this is for us to put forward for out here to consider for our students as they're embarking on their professional paths, and for ourselves to see where we have come from, where we are, and where we have potential to head in the future. So I'd like you to consider following questions. Again, these can be discussed in a classroom or in a clinical setting or individually. But what nursing theory seems consistent with the values and beliefs that guide my practice? Does this theory reflect nursing practice as I know it? Can the language of the theory help me explain, plan, and evaluate my nursing? Will those from other disciplines be able to understand, facilitating cooperation? Will other nurses find my work helpful or challenging? And what is the evidence that the use of theory improves nursing care? So these are questions to consider. It's amazing what comes up when we do stop for a moment and think and reflect in our very, very busy lives. So in addition to the above, moving forward, we need to include all types of knowledges in our research, education, and practice by broadening our perspectives and understanding of what constitutes valid knowledge. For example, indigenous knowledges, wisdom, intuition, creative self-expression, spiritual knowledge, artificial intelligence, created knowledge, and so on. The future is wide open, and all we have to do is reflect on where we have been, note where we stand right now, and look forward to the future in a humble, collective, collaborative way, moving forward as we evolve as individuals and professionals and as humanity. So in summary, paradigm or worldview provides framework for generating knowledge. It dictates what sorts of knowledges are considered acceptable. Empiricist or realist view versus interpretivist, idealist view is something that we need to consider, but we need to look at all perspectives. Abductive reasoning is more than inductive and deductive logic. It expands beyond information at hand. And as John Dewey noted, all reflective thinking is a process of detecting relations. Nurses are active participants in creation and advancement of knowledge. And this is another opportunity to engage in reflective writing. And this is what I included at the end of all of my talks and classes as well, is what did I learn today? How does this learning inform my practice or thinking about practice? What puzzles me today about patterns of knowing? How will I further expand my understanding of knowledge development in nursing? So as this was intended for a presentation that was going to be followed with questions or comments, I invite all of you to consider what questions come up for you, what comments you would like to share with each other, and then discuss those within your collective group, and enjoy creating knowledge and working together. But don't forget the person in our care. As nurses, we need to keep that in mind. And by person in our care, I mean the patient and family, depending again on the context. Thank you very much for your attention and your time, and I wish you well.